Whenever you're ready.
Just those of us in the room, we're going to do osteonecrosis of the jaw and that sort of thing. I apologize because I would have come right down and talked directly to you, but in order to keep this electronically, I'm going to try to behave today and stay behind the microphone where I belong.
Perfect. Thank you.
I have met everybody. I haven't met you. I'm John.
Edwin Johnson. I'm from right around the corner here, St. Mary's.
Very good. And you guys are down the way.
Tampa.
Joan Levy from the MMRF.
And I'm Ken Lees from New Hampshire.
New Hampshire. Well,
Long way on.
came down to get warm.
Hampshire.
Hampshire.
How Hampshire.
I'm from Kansas City. Basically, have lived there all my adult life. I went to Kansas City in 1964 to go to dental school and ended up staying in the Kansas City area, returning to the Kansas City area after I was in the Army for a couple of years. And had 23 years as a private dentist in a family-oriented preventive dentistry practice, and then 25 years at the University of Missouri Kansas City School of Dentistry. I was a clinical faculty member for the first 15 years. In the last 10 years, I was one of the associate deans of the school. And I loved every day of dental education. I still do. We're going to talk a little bit about why multiple myeloma patients need to be aware that there is a condition called osteonecrosis of the jaw that can affect us more frequently than it does the general population. So that's why we're here this afternoon, is to learn a little bit more about what osteonecrosis is and things that we should keep in mind when we're interacting with our care team, which includes the dental part of our care team, and what we should be aware of happening in our mouths or might happen in our mouths that could lead to the process of development of osteonecrosis. So it says osteonecrosis of the jaw. This is a condition that has most frequently occurs in the jaw. I've seen some literature that talks about it, specifically one paper that was published related to a child in France that had it in their leg. And it's beginning, some of the research that's just recently come out and been presented in poster form at some of the recent meetings is identifying osteonecrosis at other places in the body, but there's not a lot that's known about the other places in the body. You can see that it's the name of it has changed over the last few years. In 2003, it was bisphosphonate related osteonecrosis of the jaw. Then in 2011, it changed again to include other type of anti-resorptive medications in addition to the bisphosphonates, which are generally Iridia and Zometa. They added in denzatumab and those others, which are also designed to help slow down the resorption of the bone. And then in 2014, it changed to MRONJ. So it has evolved over the years. The name now is medication-related osteonecrosis of the jaw. That's where the MR in the MRONJ comes from. And that comes out of a physician paper that was written by the American Society of Oral and Maxillofacial Surgeons in 2014, and it was a 16-page white paper that defined what this particular entity was all about. So just in the last, since 2003, the information that we have about it is increasing, and we don't have a lot of information, but it is on the upswing at this point. So the bisphosphonates, and a lot of us have been on them because of our myeloma. There are women who have been on them because of osteoporosis over the years. And the concern comes in any of us that these medications are very, very, very slow to move out of our system. We talk about them having a very, very long half-life in the body. which means there are some medications, just the quick one that comes to my mind, when you get melphalan for transplant, that functions out of your body within 24 to 48 hours. It's gone. It's done its job and it's gone. The bisphosphonates will stay in a person's body and for a year, 2 years. They're very, very slow to be processed out of our bodies. So over the time frame, if we're being given bisphosphonates or these other anti-resorptive medications, it just fills up and it stays forever. And we're going to come back to that in a little while when we talk about the idea of a drug-free period before you do dental work or something. But it's important to know that they stay in there a long time, and that's what they're designed to do. They're designed to help strengthen the bone. They were initially designed for people with osteoporosis, and they were designed to continue strengthening the bone of those patients for a long period of time. So with all of the things known to myeloma, the doctors have to monitor for renal dysfunction or damage to other of our internal organs, and to make sure that there is not any very, very immediate problems going on in the process. There is 1 or 2 papers that say that malignant cells produce osteoclast activating factors. And so if that applies in myeloma, that means that our myeloma cells stimulate the osteoclasts, which are the cells that break down bone. Osteoblasts are the cells that build bone back up. So for example, if you go to the orthodontist and they put pressure on a tooth to move it one way, the osteoclasts break down that bone, and the osteoblasts come in on the other side and build new bone back up. So there is one paper that talks about malignant cells have the ability to stimulate the osteoclasts to break down that bone. This is one of those pictures, I'm sure you've seen it before, of a multiple myeloma patient with those lytic lesions in the skull. It's very, very obvious where those lesions are. It gives that Swiss cheese effect. You can see them in the bone of the arm on the other picture. The patients that I have in this slideshow are all patients that were treated at our School of Dentistry. We had a special patient care clinic, which evolved into a oncology support clinic. And so all of these patients were seen in the school by our pathology department and our faculty. This is a dental x-ray that shows the lower jaw on the bottom, the upper jaw on the top. You can see that this person is missing a lot of teeth. Not a good patient, not a good patient that's in good repair. And when you look at a dental x-ray, the tooth on the very left-hand side at the top, you see it's all white. That tooth has a metal crown on it. It's had a root canal done on it. The tooth on the lower right, your lower right, has a filling in it. That's the white spot. And then the missing places are missing teeth. But if we look right here, you see what looked kind of like a crater. The jawbone should come down just smooth right there. That's a place that a tooth was taken out. It was probably taken out because it had gum disease going on around it, and that socket where it was being held in was deteriorating, and it was taken out. So we're going to talk about places that osteonecrosis may appear. This slide also shows some of those punched out lesions in the lower jawbone to show you that it can affect basically every bone that we have. And I kind of think about those osteolytic lesions that we have in multiple myeloma as, you know, they're trying to break out. They're destroying the bone, and they're it's just kind of trying to break out. So I put the break out of jail picture in there. But this is one of those circumstances where, as we mentioned earlier, if you're getting a bisphosphonate to strengthen your bones, it might have unintended consequences when we talk about osteonecrosis. It may come back to get us. We mentioned that the American Association of Oral and Maxillofacial Surgeons put out the white paper, and there are very specific criteria that should be looked at when a patient is being evaluated for osteonecrosis of the jaw. They've already had anti-resorptive agents, we know that. Anti-anogenic agents. There should be exposed bone somewhere in the mouth, because we're talking about oral osteonecrosis, that's been around for 6 to 8 weeks. It's not something that is a short-term thing. You want your dental professional to be watching it, be aware, or you as a patient be aware of what's happening. Yes, sir.
Now, how are you
Sound is
determining
pretty
that's a
good now.
bone? Are you taking X-ray to further visualize it in there?
Question was, how do we distinguish between a circumstance where there might be osteonecrosis going on, where the bone is exposed to the mouth, or a piece of tooth? And the easy answer to that, the quick answer, is take an X-ray. But let's keep that in mind, because we'll talk about that a little bit more. And the patient should have no history of radiation treatment in the area of the head and neck. And that's radiation treatment, that's not dental X-rays, that's treatment. So why is it important to us? We mentioned that the bone remodels, the osteoclasts break it down, the osteoblast builds it back up. When it breaks down, that dead bone kind of accumulates. It doesn't go away. It should go away, but sometimes it doesn't. Possibly there's a place where trauma has occurred in the jaw, an extraction site, where there's been a previous area of trauma where the jaw has been hit, and it stimulates the cells that are down inside of the bone. There often is infection in that particular area. Like so many of us, myeloma patients, we have a caregiver that's right on top of everything throughout the process. This particular guy's wife kept a daily diary of what was happening with him in his myeloma and what he was sharing with her as his symptoms of going through the process. She was a little bit more obsessive than my wife. My wife kept a diary, but not quite to this point. And she was there with the care team to answer the questions that the patient was not able to answer. an important thing. So we showed a picture a minute ago that showed where a tooth had been extracted on an x-ray. That tooth is missing right there. And I said on that x-ray, if you're really looking close, you can see that little kind of dark place on the film. I did kind of a circle motion. That little dark place on the film was this bulge
Loud and clear.
of bone that is exposed to the mouth. That's typically the way osteonecrosis appears the first time it's in somebody's mouth. There's something that causes that gum tissue to pull away and expose that bone. It could be the bone growing and putting pressure against the gum tissue and forcing it out, or it could be that the gum tissue dissolves. And in some cases, it could be a circumstance where there might have been an extraction in the past, and either a little piece of loose bone or a little piece of loose tooth has worked its way through the gums. That's not osteonecrosis of the jaw. That's just the healing process of getting rid of those loose pieces. But this is that guy's
Keep it crackling, but not disturbing. Presentation sounds clear. Good.
You're going to look at another patient. It seems to occur most frequently on the lower jaw, almost always on the inside of the lower jaw, very, very infrequently on the roof of the mouth and the palate of the mouth, but mostly on the lower jaw. Another patient who had some extractions here. This extraction on that side was several years before this x-ray was taken because the bone is healed over. But you can see kind of rough, irregular shapes on the x-ray there. And even a person who doesn't know how to read x-rays can see that that's rough and the other one is smooth. Those white places are metal fillings in the tooth. So osteonecrosis in the jaw, or MRONJ, medication-related osteonecrosis in the jaw, most frequently occurs in patients who have been on long-term Iridia and Zometa. Good. The question was how long?
Define long-term.
Often, yeah, define long-term. Often term, in my particular case, I was on Iridia for 2 years. And because of my knowledge and that sort of stuff of what that might infer to me, my doctor and I made the decision to take it off. But there are some patients who have been on it prior to myeloma diagnosis for many, many years. So to define too long is hard, but the general consensus of opinion is a 2-year time frame will help the multiple myeloma patient. You may come back several years later if your disease is relapsed and it's becoming very active in the bone destruction phases from the lytic lesions and start over again.
But it's a USB mic.
But generally the thought is 2 years is the ideal.
Even if you've only been on Zometa for a few months.
If you've been on Zometa for a few months, they think 2 years is appropriate.
Okay, now.
Because it is important that we strengthen our bones in multiple myeloma. So many of us have those fractures and stuff, and it's important to strengthen them. Okay, it doesn't happen very often. MRONJ or osteonecrosis of the jaw doesn't happen very often. It happens in 0.10%, 1% of the population generally. But the concern for us is that it happens 3 times as frequently as it does in the general population because of those challenges that we face with what's going on in our bones. So for a myeloma patient, it's a little bit more important. And interestingly, research that's been reported in the journals say that it occurs more frequently in myeloma patients than it does in metastatic breast or cancer patients. Probably because our disease happens to center in the bone and in the bone. So we talked about the half-life. The half-life can be easily up to 2 years. It can even be longer than that. And if you're getting it this month, this year, then it's 2 years from there. And so it's very long. And so meta seems to be more related to osteonecrosis than iridia. And I said seems to be, because there's not specific data, but looking at patients, that's what it seems to be. And a transplant and high-dose chemotherapy don't seem to contribute to it. So it doesn't matter. That's not a contributor. It generally occurs in patients over 65. That's when myeloma generally occurs. It can occur spontaneously. As I said, something may stimulate the gums to pull back from the bone and expose it, or something may stimulate the bone to grow and grow out through the gums. We don't know. But we do know, as in the pictures that I showed you, it occurs more frequently in an area that there has been dental trauma. That could be the extraction of a tooth, or that could be a trauma where you've gotten hit on the jaw or something like that. So dental trauma is probably one of the stimulating factors. It could be denture wearing. People who have dentures that are wearing sores on their jaw, that can stimulate it. Smoking, we don't know, we think. Diabetes, we don't know, we think. There's no test to determine whether you're going to get it or whether I'm going to get it, because it is so infrequent. About 10 years ago, it was about the time that I was diagnosed, there was a faculty member at our school your dentists are the very, very most important thing. The same thing we always say. The first time I spoke to a support group in St. Louis, a lady came up to me or raised her hand from the back of the room. And I was talking about make sure that your dentist and all your healthcare providers know the status of your myeloma, that you have it and what's going on and what medications you're taking and that sort of thing. She said, I can't tell my dentist those things. And I said, why? And she said, because I knew him when he was a young boy. He was my next door neighbor. He grew up and now he's my dentist. And I said, I work at the dental school. I will tell him if you don't. I had no idea whether I knew who he was or not. But I saw her a year or so later and she said, yes, she did have the conversation. It's a very important conversation to have with all your healthcare providers so that they know what's happening with you. We talked about the longer you're on those medications, maybe it occurs more frequently. We talked about the idea of doing a drug holiday. If, for example, you're anticipating some major dental work 6 months in the future, talk to your care providers. You may stop it, but again, keep in mind that it has a very, very long half-life and there'll still be some around. But some people do choose to stop it. But don't stop it a week before and expect it to happen. Make your plans appropriately so that you can get the care that you need. This is another patient. This is a patient who was actually in our support group, and he's kind of the messiest one of the whole bunch. You can see he has broken down teeth. Actually, if we could see his bottom front teeth, they're very, very dirty. They're covered with tartar and calculus. He had an extraction many years ago in that area, and he still has that broken tooth adjacent to it. And this is the place where the osteonecrosis developed. So it's probably, in his case, a combination of that extraction. There was trauma to the jaw, and then the fact that this whole thing is in here wiggling around and being a source of infection. That's a picture of the same gentleman. You can see that broken down tooth back there. But you can also see that those osteonecrosis places are beginning to move all the way up around that lower right-hand side of his jaw. And on this x-ray, we just saw those pictures of those 3 bumps, one of them exposed. And on that x-ray, you can see the 3 bumps. Yeah.
So are you saying that where the osteonecrosis started?
I mean, the
where he had it
microphones on this
extracted,
computer are
Did he have it
really
extracted
good.
while he was on?
So I think with
The question is, in this patient that we're looking at right now, was that previous tooth extraction done while the patient was on Zometa or Iridia? I don't know. the
default
answer to that.
microphone
I don't know.
in microphone.
I'm going to guess. I'm going to guess.
When I do that, it
I'm going to
turns
guess. To Iridia, I actually had a root canal done preventively because the tooth had been bugging me, and it was a lower wisdom tooth, and why I still had it, I don't know, but I still do. I had the root canal done preventively so that I didn't get into myeloma treatment and have the infection more up in that tooth. Potential sites, if that broken down tooth that man had in the pictures before, if that broken down tooth had been taken out when the other one was taken out, if it was ready to be taken out at that point in time, that could have been a
sorry, lost connection. Good now.
And the current
Can you hear me
philosophy
now?
of the American Association of Oral and Maxillofacial Surgeons
Can you hear me
is
now?
that
If I
multiple
whisper,
myeloma, active multiple
1,
myeloma
2,
patients
3,
are not
4,
currently
5, 6, 7,
considered
8.
candidates for implants. If you have implants done in the past, it's critical to keep them perfectly clean. But most oral surgeons at this point in time don't do implants on myeloma patients.
And Michelle.
Here, I think this is the final guy.
It's not Michelle, it's
He
Stephanie.
has the place down on the lower jaw. There's a lot of dental work that's been done, crowns on a lot of those teeth. Relatively clean, but a little bit of tartar calculus building up on the back of his lower teeth.
It's Stephanie, it's not Michelle.
There we see the x-ray again. You guys are getting to where you can see these bumps and know that that's abnormal. This is the one that we saw in the picture that was protruding through the
Stephanie.
gum. So what do? Keep ourselves clean. If there has to be any oral surgery done, any of those things, be sure that you're covered with antibiotics. There is an oral rinse called chlorhexidine that oftentimes people use as a rinse to eliminate infection in their gums. That could be preventive for osteonecrosis. Any mobile bone fragments that are in there, get them out.
I want why that's not.
Chlorhexidine rinses. There have been a couple of studies trying hyperbaric oxygen chambers for these patients, and they don't seem to be effective. There is a new low-level laser that's being developed and that's currently on the market, and that seems to be helpful. But I kind of, I don't quite get it, because if you have an exposed piece of bone and you laser around the gum tissue around it, I think the concept is that that will stimulate the gum tissue to grow more than it would otherwise, and it may grow back over. The ideal circumstance is over periods of time, if it's kept exceptionally clean, you're on top of it, use chlorhexidine rinses. The goal is to get those to close. But the big ones are very, very slow. Like a big one, that big around, that may be 5 years to close out. It's very, very slow. See what we said, natural healing is very slow. And that's about it. I have answered questions for sure, because they always come forward. Yes.
There's no surgery recommended for when you get this osteonecrosis of the jaw, nothing like that? They don't do?
Question is there surgery recommended to close that? No, there isn't, because if you were to think about doing closure of that space, you would be putting sutures in that gum tissue and trying to pull it together, and it doesn't pull. It has to grow in naturally. So there's not surgery to do it. To break that piece off, if you broke it off or removed the bump surgically, you would not have as smooth a surface as the natural bone surface to try to get that gingiva to grow back over. It would be rough, and it would be irritated, and it would probably make it worse. Yep.
So we're talking about that, the gum, we want that to grow back over, and that's going to take time on its own. But what about the bone underneath that's going to, I mean, it's osteonecrosis of the jaw bone, right? And that bone that's exposed is alive as long as the gum is over it.
The question, it relates to the bone that we see exposed in osteonecrosis. And we were thinking about having the gums grow back over it. The vascular supply to that bone is probably decreased. So the surface stays smooth, but something on that outer surface has stopped growing the connection of the gums, the gingiva, to the bone. And so, kind of in answer to your question, that bone is probably less viable than the rest of the bone in the jaw. And so to try to get gum tissue to grow over that less viable bone is a challenge, because there isn't blood supply to the cells on the surface of that bone.
I have a question.
Sure.
Is there a test or labs or something you can do to detect osteonecrosis other than oral examination and x-rays? Is there any other way?
The question is there a test to identify if you're going to have osteonecrosis or if osteonecrosis is on the way? No, there isn't a test. That was one of the things that lady at our school was trying to determine, if she could look at x-rays and predict where osteonecrosis might occur in the future. And there is not a test. You can't put a piece of litmus paper in there or do a blood test to see it come. Again, we have to remember, it only occurs in 1% of the population. But for us, it occurs 3 times that.
And also, why are implants, myeloma patients not good candidates for the implants?
I said earlier that the American Society of Oral and Maxillofacial Surgeons say that myeloma patients are not candidates for implants. And it has to do with the structure of our bone. Because of those lytic lesions, if you're doing a dental implant, you may be going down into the area where those lytic lesions are active, and you don't get the bone growing back around the implant to make it secure.
Or
Because, yeah, and it may stimulate other problems.
Okay, I have dental implants and they were
Do you still hear
done
me
prior to my diagnosis.
when I talk?
But I mean, I'm okay, but I have no way of knowing if that could present a problem right down the road.
Yeah, the patient mentions that she had had dental implants done before she was diagnosed with myeloma. And that was several years ago, and they seem to be doing fine. You also have the advantage that they're on the upper.
Yes, it's a palate.
It's the upper ones, which osteonecrosis occurs less frequently in the upper than it does in the lower. And if it was done before there were active lesions going on, and I don't know whether you have lytic lesions in the upper jaw or not, if it was done before that, then we would hope that the bone has healed around it and is holding it firmly.
And I did stop the bisphosphonates, you know, when they were finally putting the implants in. I stopped
And
that.
she was on one of the bisphosphonates and then now has stopped that. So with all of us, cleanliness, being aware of it, don't let it, if something is amiss, check in and have them check it out.
Do you consider crowns to be trauma to the jaw?
The question is, do I consider crowns on a tooth to be traumatic to the jaw? Generally, a well-placed crown may go 0.5 millimeter below the level of the gum tissue, which is well away from the height of the bone. And crowns are generally a very, very fine restoration and would not, in anybody's mind, I think, be conducive to osteoporosis.
What about having, and you might have said this, endodontic work with root canals done?
The question is, what about having root canals or endodontic work when you're on the bisphosphonates? I mentioned my example that I had a root canal done right before I started on the bisphosphonates. A properly done root canal is contained completely within the structure of the tooth roots. And so therefore, it should be perfectly fine. That's one of the alternatives that we have as patients to extractions. If the tooth is sound, needs large repair, endodontics is a very viable option. Thanks for spending the afternoon with me.
It's not good.
Can't pull it up. I'll have to get it off my computer instead.
Can you still hear me when I talk?
Hers was